Hello. Professor Julia Ruckledge is a Canadian-born clinical psychologist, and she is the director of Te Puna Toiora, the Mental Health and Nutrition Research Lab at the University of Canterbury in New Zealand. Ruckledge has over 10,000 citations, an H index of 49, and Ruckledge and colleagues have published dozens of papers looking at the impact of micronutrients on not only anxiety, ADHD, and depression, but on overall well-being, and the role of nutrition in producing a more resilient person in the face of traumatic life events. Maternal nutritional status plays a vital role in all phases of fetal development, including brain development. And today we are talking with Professor Ruckledge about the NUTRIMUM trial, a world first, the first ever RCT for nutrient support in pregnancy. A 12-week, fully blinded, randomized, placebo-controlled trial, and this novel RCT is the first to study efficacy and safety of micronutrients as a treatment of symptoms of depression during pregnancy. This is the Bradley paper that we'll talk about. As a NUTRIMUM trial follow-up, Ruckledge and colleagues assessed infant neurobehavioural development in the first month of birth, the Campbell paper, as well as the impact on birth outcomes, the Heaton paper, comparing infant outcomes with controls. The three papers together paint an extraordinary picture. We're left questioning whether current recommended levels of nutrients are actually safe. Underdosing may be causing more harm than any purported toxicity risk. And we're also left thinking about the cost-benefit ratios of micronutrient dosing versus antidepressant drug use in pregnancy and postpartum. So we're going to try to get a handle on these three important papers today. Thank you for joining us today, Professor Julia Ruckledge. It's fabulous to have you here, and I can't wait to dive into these papers.
It's my pleasure. I'm delighted to be able to share this information with the world.
It's wonderful. Thank you. So let's talk about, we're talking about the Bradley paper to start off with.
Mm-hmm.
Can you start by explaining the methods and structure of the trial, please?
Sure. Okay. So NutriMum was when Haley Bradley came into my office to want to do a PhD with me and wanted to change the world, as so many of my graduate students want to do, I said, well, really the place to start is that where we need to go is look at the effects of micronutrients on symptoms of antenatal depression in pregnancy. And so we set up NutriMum, and NutriMum thought a lot about how do you do this, how do you set up a study like this, how do you, in terms of the design. And we decided we really needed to focus in on the space of the antenatal depression and focus in on that rather than make it overly complicated and think, okay, well, we can look at postpartum and we can look at all these other things. Let's really focus in and do a control trial during the second trimester of pregnancy and see if we can help these women with their symptoms of depression. So we got it through ethics. We got it through MedSafe, where they approved the use of the nutrients at the levels that we were giving them in at, which was above the RDA, but below the upper limit. And this is, for most of the nutrients were below the upper limit. A few of them are above the upper limit, but not dangerous. The upper limit sort of identifies a level where if you go higher than that, you increase the likelihood of toxicity. But they're all of the ULs for nutrients is based on just giving that one nutrient by itself, which is not the way we consume nutrients when we get the nutrients out of our food. So something like zinc, the upper limit is based on preventing a copper deficiency. So if you give zinc with copper, then you end up with having being okay to go above that. So there's some logical reasons why some of the nutrients are being given above the UL. So we studied what we've been studying in my lab for a while now, which is a product called Daily Essential Nutrients. Nothing special, but it just has the full blend of micronutrients that we know that are essential for metabolic function, all kinds of different activities and chemical reactions that are happening in our body. We're completely dependent on the presence of these nutrients. So our placebo arm had had iodine in it at 150 milligrams, and that's because the Ministry of Health states in New Zealand that that's the only recommended nutrient after the first trimester. There are some other nutrients that are stated on the Ministry of Health website, like vitamin D, but they don't actually say you should necessarily supplement with vitamin D. They just say go out and see if you can get it out of the sun, which is kind of sometimes a bit ridiculous because that means that they don't understand that in winter you cannot get vitamin D easily out of the sun, because it's got to do with the angle of the sun. And so you kind of do wonder where in the world do they get their science, but that's an aside. Um,
So
so yeah, and there was some
this trial
riboflavin.
was held between 2017, you recruited between 2017 and 2021, and
Yeah.
there were 88 women in the trial.
Yes, correct. Yes. So there's 88 women, and they were randomized 44 to the placebo or 44 to the micronutrients. Now, the placebo also had riboflavin in it, and the riboflavin was important because the riboflavin can change the color of urine for some people. So that meant we can really confidently say to people, if you do see this happening, it's not a giveaway of what condition you've been randomized to. So we want to make sure that it's completely blind. So the mums were monitored through this 12 weeks. They were either by filling in questionnaires every couple of weeks online, or coming in to the lab and meeting with either a clinical psychology graduate student or a psychologist to just review how that mom was doing in terms of symptoms of depression and other things that are just overall get a sense of her overall life. So that's the trial. That's the setup of the trial. And so should I jump into the outcomes? So we've got a few that I want to highlight. So one of them is that, and you might think that this isn't a good news story for the micronutrients, but I'm not here to either. We're here to just do the research and see if we can find things that can be beneficial for women. And so the first thing that we found was that there was no group difference on the EPDS, the Edinburgh Postnatal Depression Scale, which is the measure we were using to identify if depression was getting better during the trial. And the reason we didn't see any group difference was because 3/4 of the women in either group went into remission. So that meant that their EPDS scores dropped substantially, and also relative to how they came in to the study as well. So they had to have a certain change in their scores in order to meet the criteria for remission. So that, in my opinion, though, is a good news story because it means that we found a really safe way to help women during pregnancy to reduce their symptoms of depression, which is the care that was being given, and also the expectation that they might be receiving something that might help them. So that's the first thing. But the second one was where we did find a group difference, where the micronutrients were found to be superior to the placebo, was that the Clinical Global Impression Scale, which is used very commonly in these controlled trials, is a measure that identifies whether or not the clinician thinks this person is getting better. Our experience with people is that people quickly forget how they were a month ago. They forget how bad things were. And so they often kind of think that they're just the same. But then when you start talking to them, you realize, oh, that they're sleeping better, or that they're coping better with life, or that they're no longer suicidal, or all these things that can happen, but that they kind of haven't noticed these changes because sometimes there's kind of a bit slow, or life can still be tough. So they haven't always been able to give it their full attention. That's my experience with monitoring people over clinical trials. So the clinician is able to give a more objective review of how that person is doing. So based on those reviews and those ratings, there were more responders in the micronutrient group compared to the placebo group, either based on the clinician rating, but also based on self-report. So it's something like 69% of the, is that right? Because you had the
Yes.
number. So yeah, okay. Of the those who were randomized to the micronutrients identified themselves as much to very much improve versus 38% of those who had been randomized to the placebo. So that's a pretty substantial difference, although it still highlights that very strong placebo effect that we observed based on those EPDS ratings. So those are the primary outcomes.
And sleep was sleep part of the CGI
Yes, yeah,
assessment?
yes, and
That's
so
huge. When people are in pregnancy, sleep is often terrible. It impacts your day, but also, of course, sleep is when a lot of learning and growth happens. So I consider that's quite relevant.
yes, it is. Yeah, no, and sleep was identified as improving, what got better more in the micronutrient group compared to the placebo group. So that's a good outcome as well, because as we know, when you're pregnant, that is something that ends up getting compromised during the pregnancy. So that was something that I guess the clinicians would have heard about, but they would have also heard about things like just coping a little bit better or less stressed, or things not bothering them as much, or not being as emotional or irritable. So those other things would have been coming out and influencing that overall judgment. So those are the two main outcomes, but there's some other things that we also delved into because these are very labor intensive studies. And so while it's very important that we stick with what we've pre-registered as the primary outcomes, and those are the two that I've just described. You also want to know, well, can we start to identify who is going to benefit? Who should we target with these interventions? Because they can be costly at the moment. It costs the participant or the patient or the person, the mom, because they're not funded in New Zealand or other places. So you do want to say, well, who's going to hopefully have the best opportunity and the best likelihood of benefiting? Or who can we just give a placebo pill to? So the when we looked at that, the two main moderators that we found was a history of taking a psychiatric medication, and also the second one was whether or not we identified them as having what we call personality difficulties, not a disorder, but just difficulties. And that was using a measure that highlights things like being really dysregulated or getting along with other people, being really anxious, just these sort of things that can start to identify people who struggle a bit more with life than others. So when we stratified the sample this way, what we then started to see was a much bigger split happening. And so those who got randomized to the micronutrients and who had a past history of medication and who had these personality difficulties, they were way more likely to respond to the micronutrients than the placebo. So that you end up with this splitting, and the placebo not very much response, whereas we saw this really substantial and dramatic response with those who had these characteristics.
And personality difficulties are reasonably common. So in the current study, you had a similar rate to the population, which was
about half.
48.9%. So I think, this impacts your capacity to get along with your partner, for people to want to see you when you're pregnant. So, people with personality difficulties will be possibly likely to be more isolated. And that in itself has reverberating effect.
Exactly.
So
that's right.
That's quite an important
Oh,
subject.
absolutely. Because if you have a finite resources, as every government does, then it could be that you could choose to target just those particular people. If you wanted to, at least a starting place, if you wanted to just sort of open the door to the possibility of helping some people with this intervention, then I'd go, okay, well, why don't you start with them? If you don't have, if you want to, you're not quite sure, but this is where we had a great opportunity of seeing some benefit. These really emotionally dysregulated women. So those were some of the highlights. Some other highlights. Go ahead.
But physiological.
Sure. Yeah. So one of the big things that I observed really early on, when we started to recruit, was that we had a lot of opposition to this study. And we had a lot of health professionals who were unwilling to to refer moms to our study. So and it could have been because they were worried about the nutrient levels. They were really high, so they were concerned about the damage, the effects it might have on the fetus. So there were all these concerns that they had, and fair enough, because this was the first study. So not that I had any reason. There was no reason for us to expect that there should be harm. After all, it got through MedSafe remarkably quickly. It got through the ethics committee remarkably quickly. So they didn't raise any concern. So that meant that we had provided enough justification for using the nutrients at these doses that there was no reason that we should harm the infant. But we decided that we should, it's important to establish, this isn't another thalidomide, that we don't want to cause harm. So we ended up collecting a lot of safety data. So within the context of the RCT component, we had we looked at things like hematology. We looked at kidney function, so liver function, just to see if there's any harm, and there was nothing there. We looked at side effects, and the side effects, there was no group differences in side effects. There was some trends of some things that were maybe a little bit more happening in the micronutrient group, like a bit of more gastrointestinal nausea. Not to the point where they wanted to drop out, but they certainly weren't severe enough, but they were being reported a little bit more in that micronutrient group, but not to a point where it was actually a significant group difference. So all in all, really good safety data. And in fact, there were some benefits that we had identified based on having to do all these blood levels. So one of the things that we did was that we did some nutrient levels. And unlike our studies that we've done outside of pregnancy, where we tend to see the nutrient levels going up in some cases, some nutrients don't go up because there's homeostasis that keeps the levels really tightly controlled in the blood. But some things you might see going up, like B12 might be one, or vitamin D can go up when you supplement with vitamin D. So typically we see those going up. But in this study, we were seeing, yes, they were going up. But what's happening in the placebo group was that they were going down. And so what I see this as what's happening here is that we're holding mom at the nutritional levels that she needs when there's this extra thing, this fetus that is sucking out the nutrients and therefore depleting her of nutrient opportunities. So there's lots of reasons why moms aren't getting the nutrients during pregnancy. We are, the research is very clear that moms are eating more and more ultra-processed foods during pregnancy that we know are nutrient depleted and deficient. So is that what's happening? And that's increasing the likelihood of problems and depression and all kinds of things. It could be a contributing factor. Research suggests that it could well be a contributing factor. So what we seem to be doing is enabling that mom to function and by giving those nutrients and not preventing deficiency happening during that pregnancy in a time where your nutritional needs are much higher. We published a study on vitamin C specifically in the NUTRIMUM component, showing that deficiency was happening for those in the placebo group in terms of vitamin C, but we weren't seeing that level of deficiency happening in the micronutrient group. So all of that those are good things. And we also saw a drop in the homocysteine, which is also a really good outcome. High homocysteine can be associated with all kinds of things, including inflammation. And so the fact that we were able we showed a benefit on homocysteine levels. Everyone should get excited about that, to be honest. I mean, it's something Absolutely. That physicians are aware of as can be a problem health-wise to have high homocysteine. So the fact that we were able to so clearly show that, and we've shown that in other studies too. It's not the first time we've shown that. It's
fantastic and homocysteine, it can be associated with higher risk of heart disease, stroke, and heart attacks, as well as, for example, folate and B deficiencies. Yeah. So it's compelling to understand that the placebo group dropped while the nutrient group, which of course were higher than what would be the normal recommended daily allowance, was sustained. That's fantastic.
Yes, exactly.
And antenatal depression affects 15 to 21% of pregnant women worldwide, and of course it increases the risk of pregnancy, but not birth and neonatal complications as well.
Exactly. So so that leads into some other things that we decided to get interested in. So because of all of this opposition we were experiencing, to be honest, I shouldn't be surprised because I've experienced it in every other clinical trial I've run. But I'm forever kind of go, why are they opposed to this when there's so much research that shows some of the detrimental and negative impacts of antidepressants on outcomes for the infant and birth outcomes. But we can talk about that a little bit more. Why wouldn't people be interested in exploring another option to see whether or not we can find a safer option? But interestingly, that doesn't seem to be how the minds of many health professionals work.
And just to interject there, the Unwin Clinic in the UK, Dr. David Unwin, a GP, and his wife, who's a clinical psychologist from the NHS of 30 years, when they started in about 2011 reversing diabetes through lowering carbohydrates, the nutritionist or the dietitian in the clinic left in disgust, and the rest of the GPs that were there then said, we don't want to have anything to do with it. It's very unprofessional. You're going to harm the patients. Whereas now, three published papers later, and it's 2024, the whole clinic is behind it, the whole clinic supports it, and the whole clinic is absolutely proud of the work that they're doing. So
I know
this can change, but the very process of you trying to go through conventional medical doctors and then getting rejected, but then publishing really positive data is itself, I consider, a compelling change agent. And we don't understand why the Ministry of Health themselves aren't leading this sort of work and funding it. But
that's true. I don't know.
Yeah, you're in a really important place. And of course, your citation the citations you're getting reflects that the world is actually zeroing in on this University of Canterbury's work here. So
yes, we can only hope that this is going to influence practice. There aren't any controlled trials that have ever been done on antidepressants, which stunned me. I walked into this whole space of maternal health naively. I hadn't worked in this space before as a clinical psychologist, so but I think that means that you just look at this area of research with open eyes, curiosity, and going, well, they use 3% of women in New Zealand get 3% of women during pregnancy in New Zealand are put on an antidepressant. Surely there's some good evidence to support that prescribing rate. And then when I look for it, there's observational studies that overall aren't painting a good picture. But there's there's a lot of conjecture on that, and I'm happy to go into that. But there's no controlled trials.
And what's really important is there's no controlled trials, but as far as I'm aware, the trials that are used to approve these drugs are short term. They're not.
Yeah, they are. They are, and they always exclude pregnant women. They always exclude all clinical trials.
And then we have the problem that women really do understand that there is a side effect risk with this, intuitively or with data. And so 80% of women go off antidepressants when they're pregnant. So without a trampoline, without a parachute they're going to suffer adversely.
Exactly. That's why I really, really hope that there's some attention paid to this, because even if there's kind of like the skepticism of the nutrients, which at this point in time, I kind of wonder why not, because we've written and published so much in the space as well as others, why not pick up on this and see and at the end of the day, it's informed. I always say it's informed consent. And so it's ultimately the patient's job. It's up to them to decide based on all of the information that's provided to them by their prescriber about what's the best course for them. And it's their choice. It's their choice to make those decisions about their treatment, not the physician's choice. And so if the physician doesn't provide the information about controlled trials that have been conducted and published in decent journals in the world, then I think that's a problem. But anyway, not that it's going to happen anytime soon in situations, but it is an obstacle that we faced. I mean, publishing NUTRIMUM, as you know, Jody, has been huge. You've been following it. You've been asking me about it, and I keep saying it's not published. It's not published, and that's because we experienced so much rejection and so much opposition to things that we were saying about antidepressants in our papers. It wasn't that all I was doing was reporting what is being published. And it was like, but you can't say negative things about antidepressants. And I'm like, but then show me a study that identifies that there's a positive outcome with these medications, and I will happily cite it. Have I missed it? That's that whole naivety of going into this space of just curiosity and looking and trying to find the studies and thinking, am I missing them? Where are they? I keep being told this is the safest medication to take during pregnancy. So where is the data? So, and I haven't come across it. So, but what I have learned from having talked to physicians about this is that there's this conjecture around the antidepressants that is interesting. And it's that I don't think anybody will disagree that women who take antidepressants they are more likely, and I've got to be very careful with the wording here, Jody, is that they're more likely to have a preterm birth and have other negative impacts. But what will be said is that it's not the antidepressant that caused that. That's an association. This is how it's interpreted. But it's other factors about that mother that lead to that negative outcome, whether it's socioeconomic status, whether or not it's depression, whether or not she was a smoker, all these confounders. And when you control for those, then that introduces this greater difficulty in interpreting the data, so that the prescriber will say, well, yes, these can happen, but we don't think it's caused by the antidepressant. So that's kind of where my understanding is of how the prescribers justify and I am sympathetic to the difficult situation that they are in that they've got someone who's depressed. They know depression leads to negative outcomes, so we can't overlook that. And so they are doing their best in a difficult situation to advise that mom around what to do.
And often they may not be aware that, for example, the Hardy Den product is well studied and is on the market, because there's not the same sort of push through pharmac, and then they're not advised. So
correct.
Again,
yes.
that means that people don't really have informed consent, because the doctor's not telling them about a product that is available because it's not coming through pharmac.
Correct. That's right. Yes, that's something that is definitely a difficulty and an obstacle around it, because there isn't a pharmaceutical company that's pushing this. This is a small company that don't have that level of resources, nor are they even allowed to advertise it. Nor are you ever allowed to advertise a dietary supplement in New Zealand to have any therapeutic benefit whatsoever. Even helping people or supporting health during pregnancy would be on the edge of being illegal. So,
for disclosure, you have never received financial support from Hardy's
correct. Yes,
products or the importers in New Zealand. However, they did supply the placebo and the
they do. Yep, they do supply the micronutrients and placebo. They are not involved in the design, how we do it. They are not involved in the analysis. They learn about the outcomes either by the publication or that they come to a conference where I present the results. And that's a legitimate thing for them to do if they want to find out, and that's how they learn about it. So I presented these results 2 years ago. 2 years ago at the American Academy of Child and Adolescent Psychiatry. Really good conference to present at. But we've only just gotten NUTRIMUM published. That's how long it took us to get through the revisions, the appeals, the rejections. I mean, it was just endless. It was harder. I didn't think it could get harder than any of the other publications, but it was. Wow. And there was so much opposition to almost everything about it. And yeah, I mean, I could spend an hour on it.
How many journals rejected
it? Yeah. That's a really good question. I mean, I try not to even dwell on that anymore, but it would probably be at least, I think it would have been 6 or 7 before I could sometimes even get it. That's just rejected without review.
Thank you very much for that.
Yeah.
people to
Yeah,
understand.
so that's but I aim high in all fairness, and
Yeah.
so the rate of rejection is very high in the ones that I like. So I'll start at the top, started at the Lancet. Um, I got a little bit of a dialogue going with the editor at least, but she rejected that review because our sample size was lower than what we had stated we were going to recruit. So that's what was allowed her to get out of it very quickly, which is,
Well, Lancet
and you're
received.
kind of like, well, that's the largest study that's ever been done. And can I just point out that there hasn't been a single study on the medications, but that didn't seem to weigh. Tried the American Journal of Psychiatry, same kind of thing. So kept going, but still, British Journal of Psychiatry Open that's a decent journal, and so it's not that but that was after a very lengthy process, very lengthy of responding to a lot of very interesting queries and
Good on
concerns
you.
and stuff. So we kept going, but it just about killed me.
No, no. Yeah, so we better move on.
That's right. Yeah. So
and that was
that
published in Early Human Development. So thank you for that.
yes. Yes, exactly. That was a very exciting research and stunningly exciting results for that one. So just again, the context of collecting data to look at harm. Siobhan Campbell came along and wanted to do her PhD with me, and I said, "Well, we've got this study going now of NutriMum, and I'm starting to think we really need to look at those infants, even though it wasn't designed for that. We've got these fetuses that are being exposed to the micronutrients. After the RCT component, they went into what we call an open label, which meant that they all got the nutrients until the birth. So now that causes a bit of difficulty in interpretation because it means that depending on what group you were randomized to, and at what point in the second trimester you enrolled in the study, and when the child was born, can influence the length of exposure to the micronutrients. So it could range from 6 months to a week. So in the Bradley study, what we decided to do was to contextualize our outcomes because we thought, well, you can do this Brazelton, but how do we know if it's good or bad? Like, is this a normal orientation? It's really kind of hard to compare it to another study because they might have used a different timing on it. All kinds of things can interfere with your ability to interpret. So what Siobhan did as part of her study was to recruit a reference group. So that's important because that's a reference group where you can then directly compare how are these micronutrient babies doing relative to typical pregnancy where mom isn't taking the micronutrients at these doses, isn't taking medications, isn't struggling with her mental health. How do they do? Sort of typical pregnancy, I'd like to call it, but it's probably, I don't know if that's the right word. We call them the reference group. And then we also, though, ended up just by nature of how we were recruiting and how people were coming and going into the NutriMum trial, we ended up with what we called the standard care group. And standard care is that these were moms who were on antidepressants throughout their pregnancy. They were not allowed to be in the NutriMum study because the NutriMum study had to have people who were medication free, psychiatric medication free, because of there's known interactions between the micronutrients and medications. So we didn't want it to be complicated by that. But they agreed to be monitored as part of Siobhan's study throughout their pregnancy and then their infants monitored. So what a wonderful group of women to not receive anything. They've made that tough choice of how they wanted to treat their mental health issues, but they've agreed to be a comparison.
So we're talking 88 babies.
Not quite. No, not 88.
Yes.
Because so first of all, not everybody wanted to go into the infant study. So not all moms, they're exhausted. They're like, they've got other kids. The idea of being in our infant study was overwhelming for some. So some did not consent to go on. And the other thing is that we wanted those infants to have a certain amount of exposure to the micronutrients. So we took the ones who did agree to go on, but we only analyzed, I think it was about 56 of those infants. Pretty sure. Is that right?
I was thinking there was a micronutrient group of 37. The group on the antidepressants are about 18, and then the control or reference group that were about 48.
Okay, that the 56 comes from the birth outcome. We had more in that particular component because that wasn't the infant study. So my apologies for not remembering all of the sample sizes of every single one of our groups. Okay, but that's still a decent sample. And that was based on that they had to have at least 2 months of exposure to the micronutrients during pregnancy. So that meant that in the third trimester, they had at least that 2 months. That's arbitrary. It's not like there was any research we could go on, but we figured that was a decent amount of exposure, a minimum exposure to the nutrients. So we've got these 3 groups. We've got these reference group, the standard care, and we've got the micronutrient group. And what we published was, in my opinion, stunning, because we not only showed that the micronutrient kids, these micronutrient exposed infants, were doing really well in those early indicators of regulation, whether that's orientation or habituation to sounds or noises or motor control, or affect regulation. So all of these different things that we were looking at, that not only were they as good as that reference group, in some cases they were better. So in every place we looked, they're either as good or they're superior to the reference group. And that's your typical kids. So that's so exciting that just giving nutrients during pregnancy gets them on a better start to life relative. And so it almost opens up these questions of, well, what should moms be getting during pregnancy to make sure that these kids have the best opportunity of a good start to life? And that's another study where I can't answer that one, but it does start to raise that question. So these kids are at a disadvantage in that their mothers they came into the study depressed. So they've started life at a slight disadvantage. So to show that we not only recouped that disadvantage, but we got them even further along, everyone should celebrate that. Like, that's just an exciting observation of what happened with those infants. And there was nothing else that could explain it. We compared the groups on age, demographics, ethnicity, all socioeconomic adversity, all these things that you might kind of think, oh, well, it was because of that they were better. No, there wasn't anything else that could better explain why those kids were doing so well. So that is a good news story in itself. The sad thing, to be honest, that we observed was the effect that the antidepressant had on those infant regulation. Now, that becomes a bit more controversial because there's a myriad of reasons why some people might think that those kids start a bit a backward step to life. There's lots of conjecture around this, and we need to just be really careful about that. So it could be that those mothers were more depressed. That's a possibility that we cannot exclude, because they came in already taking antidepressants, and whereas from the start. And so we didn't know what their depression would be like if they weren't on those antidepressants. So there's other things that could explain why those kids were more disadvantaged when we were looking at regulation. There's a lot of suggestion that the effects of antidepressants are typically acute and short-lived. But we also know that poor function on the Brazelton can have some predictive value down the road. It's difficult. So we'd need to monitor that. But the problem is that the sample size is small. So, we have to also be mindful of that very small sample size. So I'm very, very cautious about that comparison, although the group differences were large. And really, you don't need a statistic. You look at the graphs and you go, wow, there is definitely a group difference here.
Yeah, so you're using the Brazelton Neonatal Behavioural Assessment Scale, the NBAS. You're looking at everything is within 28 days of birth, so it's a very short time period.
Yep.
And that that what it looks at is infants' capabilities across 4 developmental areas, like you said: autonomic stability, motor development, state regulation, social development. And that's and involves, though, 28 behavioral and 18 primitive reflex items, and it has good reliability. It's used commonly. So
yes,
it's,
and there was a lot of training that had to go into that, and we had a second rater as well, who got the videos and assessed them blind to the group allocation. So and the reliability, inter-rater reliability was excellent. So that gives us confidence that there wasn't any bias that is creeping in to the ratings that were being done to show superiority of one group over the other. Also know that at the stage when the infants were being assessed, we didn't know what they had been taking as terms of placebo, micronutrients, all of that. So that was still blind at the point that these data were being collected. But the raters would have known whether they were a sort of a recruited through one route versus the NutriMum route. So it was impossible to keep that kind of information blind. But we did everything we could to try to mitigate that by having a second rater, et cetera, et cetera. So I'm really confident that these results are robust from that perspective of bias and other potential confounders that can impact on your results.
That's so important. The effect of NBAS occurs over that first 12-month period, but what you say is that in your paper is that over time the infants may have further problems in toddlerhood with emotional regulation and delay in language development, which can then lead to poorer academic performance and social skills and more behavioral problems at school compared to infants non-depressed mothers. And so at 6 years they can have a lower IQ.
So it absolutely. So it doesn't mean that every kid who does poorly on this isn't going to end up with a negative outcome. But the sobering that we did not expect to see what we saw with the antidepressant babies, and it's heartbreaking for us as researchers to observe this. But then when we go to the literature, it's there's other documentations of these outcomes on these kids. So at what point do mums get that informed consent information provided to them that this can happen?
And any medical doctor looking at this, they're very used to judging the uncertainty around what if that mother comes off the medication.
Exactly.
We can judge uncertainty about what are the benefits if they go on, onto nutrition. In the paper, micronutrients, for example, were a significant predictor of performance on habituation, regulation of state and autonomic stability. Whereas, for example, exposure to medication was a significant predictor of performance on orientation. Whereas, for example, infant sex was a predictor of performance on regulation of state. I do recommend medical doctors listening to this hop on that paper and make themselves familiar with what you're finding here.
Yeah, exactly. And if there is a question about the sample size or just how we design the limitations of the design, because they weren't randomized to micronutrients or antidepressants, so that in itself is a limitation that we acknowledge, then it should open up, let's do more research, because we are exposing 3% of the 60,000 babies that are born every year in New Zealand to antidepressants. So that's several hundred every single year. That has to be important. That outcomes of those kids really should be important. And so to want to start them on the best start of life, then by all means, do another study. Do it independent of me. Fantastic. Delighted. Would be over the moon. Happy to help. Whatever I can do. I'm all for replication. Absolutely all for replication.
Absolutely. And while you're talking, I'm showing you the images in figure 2, which are looking at, so it helps you see the graph. So the higher scores on habituation, orientation, motor regulation of state, and autonomic stability indicate better performance, while the lowest scores on the reflex cluster indicate fewer abnormal reflexes. And the font's a little bit small, but hopefully that will help people really see the shape of what you were finding out.
Yeah, exactly. So really surprised that we went and, oh goodness, the number of checks and balances we did on these data before we published them, just because if you're going to publish this kind of study that's not only showing the benefit of the micronutrients, but also potentially highlighting some not so good outcomes for those antidepressants. We have to be, obviously I have to be confident with every study I publish, but this one in particular is like, oh my goodness, when we first looked at those graphs.
And just as a final note on this particular paper, in the conclusion, you stated that not only did the micronutrients successfully improve psychological functioning and birth outcomes, but they also appear to have mitigated some of the risks associated with antenatal depression and poor infant outcomes, particularly when taken at a high dose and with a more balanced variety of nutrients compared to typical over-the-counter antenatal nutritional supplements.
Yeah.
So the women on the nutritional supplements weren't showing the benefits or the stability in their bloods, for example.
Yeah, exactly.
People on the high dose.
Yeah, so we couldn't exclude mums who were taking supplements during pregnancy from that reference group. We would have ended up with nobody if we'd said that was an exclusion. So we accepted that they would be taking things, but we also knew that they would be taking them generally, typically below the RDA, because that's all that's allowed in a dietary supplement in New Zealand. So we were confident that we knew that those doses would be really low relative to the micronutrient intervention that we were using. So they were on that, and there was I can't remember, you might know, Jody, but it was around 80% of them were taking something. So the fact that we weren't seeing that acceleration in early infant development in that reference group relative to our micronutrient babies really does say, oh, we really should be looking at the nutritional environment of these kids. We should be doing that. Yeah. So overall, really excited, like just such a wonderful paper that Siobhan published earlier this year. So really thrilled. And she's now graduated and got her doctorate.
Well done.
As is Haley as well.
Siobhan. And let's move to the Jessica Heaton-led paper looking at the effect on maternal and infant birth outcomes in this observational secondary analysis of NUTRIMUM.
Yes.
So
this published.
This Heaton paper looks at birth outcomes from mother-infant pairs. Mm-hmm. 54 mothers were exposed to greater than 8 weeks of the micronutrients during the second and or third semester of pregnancy. 20 mother-infant pairs were exposed to antidepressants at any stage of the pregnancy, and 55 were the control. They were the mother-infant pairs not exposed to the NUTRIMUM study micronutrients or the antidepressants during any stage.
Exactly.
And just as a note, the mother-infant pairs in the micronutrient group were exposed to an average 113 days of the NUTRIMUM.
Exactly. And so they had at least that minimum of about 2 months of exposure. Again, arbitrary, but we had to have some kind of cutoff because there were some mums who were exposed to 10 days. And we thought, well, that's not probably going to really do much. Yeah. So that's why we had sort of that cutoff, and that's why the sample size is smaller. But also understand that one thing that people do get confused about is that they kind of think our control group is the placebo group, and they're not. The placebo group is, because of our design of an RCT plus open label, it means that the placebo group is now could potentially be in that space, in that group, in that micronutrient group, because if they had gone into the placebo at 12 weeks, they end RCT at 24 weeks, then they could have had 12 weeks of exposure, or even longer. 24 could have had 16 weeks if they went to 40 weeks of pregnant gestation. So just to make that clear. Yep. So do you want me to talk about those outcomes?
Absolutely.
Okay. So again, really stunned by the findings here. And again, probably because I've gone through this whole study with so much opposition and so much concern around the risks and the harms that we might cause, that if we see anything that's of benefit, it kind of surprises me. So we're looking to make sure that we haven't increased the likelihood of premature birth, that we haven't, there's not a whole bunch of low birth babies, that they're born to size, that there's good outcomes, there's, that kind of, those types of things. So all for the entire, everything that we looked at was a good news story when it comes to the micronutrients. They are either on par with our reference group or they're superior. So most things, there's no group difference with the reference group, whether that's on the number of premature births. We had 5% of our micronutrient babies were premature. They were but only early. It was only in that 32 to 36 weeks. There was no super early babies. There were no 27-week babies in our micronutrient group. There were no premature births in our reference group. The average in New Zealand is 7.9%, just so that you can say, well, actually, even though it's a little bit higher, it wasn't statistically higher, and it's definitely below the Canterbury average. So that's really good. There were no group difference on birth weight with that reference group. There was a little bit more infant resuscitation in the reference group compared to the micronutrient group, but that wasn't statistically significant. Where there was statistical significance was on postpartum hemorrhaging, something that we just measured because it's measured. You get these birth records and they tell you how much blood loss there was. And if there's greater than 500 mils of blood loss, you call that, the term is postpartum hemorrhaging in a vaginal birth. So we only looked at those who delivered vaginally. And so in that, the rate of postpartum hemorrhaging in the micronutrient group was, you probably have the numbers in front of you. I just have a graph, which is around, I think it's about 8%, and it was 30% in the reference group. So there's a massive reduction, and we don't know why that happened. We wonder about the vitamin K content and of the micronutrients. Is it just that? Is it something else? We don't know why we observed that, but it's the observation. It's there. We published it. It's something that we identified. There was no group differences in NICU admissions with the reference group. So all in all, wonderful again, because those we know that depression can increase the risk of all of those things happening. We didn't see it. And in any case where there was a significant group difference, it was advantaging the micronutrient group over that reference group. So all in all, I think it was just a stunningly exciting findings in itself when you compare it to the reference group.
Absolutely. And my impression is once you have a synergistic mix of beneficial nutrients, this is me speculating, that the epithelium, our body organs, everything is going to be more robust and healthier. So you've got less, the hemorrhaging just is probably less likely because of all these different benefits, but that is pure speculation.
Yes. So we were thrilled to see that, because again, thinking about from the risk perspective, we can really confidently say there was no observation of any harm. Now, it doesn't mean, and I'm just being really cautious here, Jody, it's a small sample. It's at 55 babies. So we can't say that some negative outcome won't happen if you were to do massive post-marketing surveillance. So there is a possibility that there is some kind of a harm coming from the nutrients that we haven't detected. We haven't detected yet in the hundreds of people that we've studied, but it's not to say that it can't hit, and it could happen in 1 in 1,000. There's no logical reason, there's no we've given something that's harmful, but we always need to be really cautious that we're not, we're careful about the limitations of what we can say on our data.
Yes. And I just want to quote from this paper, which talks about the difference with the infants and mothers exposed to the antidepressants during pregnancy. I really want to hammer this in because it's so important. In contrast, the infants and mothers exposed to antidepressants during pregnancy were found to have a higher rates of adverse birth outcomes compared to the micronutrient group or the reference group, including increased rates of PTB, 20%, infant resuscitation, 45%, and postpartum hemorrhage with the vaginal birth. That was 26%. They had a shorter infant birth length. So weight is not necessarily, because of course diabetes can increase weight, but infant birth length is always an indicator of health, because
they were 2 centimeters shorter.
That's significant. That's stunting.
It was statistically significant, and the effect size was large compared to the micronutrients. Yeah.
And so while not statistically different
on weight,
they also had almost twice the rate of NICU admissions, 15%.
Correct. Yep.
That's it's alarming to see that even this small sample size could show such a difference.
So you can imagine when we saw those data, we were alarmed and we wondered, is there something about our sample? Is this if these are the normal, if this is what's happening on a regular basis, you would think that we would have heard about it. And, when you always hear about the safety of these antidepressants is really well established. It's the safest thing for people to take. And I've heard it so many times in this whole last 2 or 3 years of trying to publish this. I've been constantly being told about that. So I'm like, is this an anomaly? Is these 20 infants just an anomaly? So I went to the literature, and so I went to see what was published. And our rates of resuscitation and premature birth are all exactly identical to what has been published. So that's when you kind of go, wow, all right, well, at least I can have confidence in our data, even though it's a small sample size, so I can have confidence in publishing these because it's not saying something that's different from what's already known. And interestingly, we looked at depression during this study for those mums who were on the antidepressants. And I'm always struck by this. And it just, again, it's like, are we just getting an unusual sample? But our mums, when they came in, the antidepressant mums, their depression levels were a little bit better than the micronutrient mums when they came in. But the micronutrient mums weren't receiving any treatment at that stage, whereas the antidepressant mums were receiving treatment, and yet their depression scores were much higher than the reference group. So you can't help but what these are supposed to be treating depression. My naive expectation when something's being treated is that it doesn't exist. It's like it's absent. So why are they still depressed on antidepressants?
Yeah.
Maybe they're the worst. Maybe these are really moms who are struggling. I can only just ask that.
Absolutely.
And maybe nothing works. And they'd be worse than they were.
And so, I'm going to reiterate what you've just said for people listening. So, and exactly using the words in the paper, the micronutrient groups and the medicated groups had similar depression scores at study entry. Those in the medicated group were already receiving a treatment for their depression. Then I'm going to repeat, at the study entry, the micronutrient group had a greater number of risk factors associated with poorer birth outcomes, including higher rates of depression, a past history of smoking, and more unplanned pregnancies. So they were more on their back foot. And let me reiterate, as you've already said, that 80% of the antidepressant group they were taking antenatal supplements, but they were typically below the RDA, so they could not confer any advantage, but they were almost misled into taking. They could be worse if they weren't.
Could have been worse. Oh goodness. Yeah, where do we go with all of that misled on supplements? I mean, diet, I know we could do another podcast on on the levels on dietary supplements in New Zealand and why they're so low and why doesn't the government do something about that? But I think we can leave that for another day because it's
And
so
just to finish,
complicated.
yeah, exactly. And just to finish off on this paper, you and your colleagues gave the example of the potential costs of not taking the micronutrient approach.
Yes.
So you just took one of the variables, preterm birth, and it's estimated the costs of a preterm infant in between 32 and 36 weeks. That would be US $28,000 in medical care delivery
Yeah.
costs, early intervention, lost labor market productivity.
Yeah.
There were 20% preterm births in the antidepressant group versus 5.5% in the micronutrient group.
Yep.
Can you just finish up talking about that, please?
Yeah. So when we did that, that was the cost analysis that we did. And I think it's 300, I think you'd save per annual cohort because those costs are based on the cost of needing more special education services and help during school and all of that. So you can't say it's an annual saving. It's per that annual cohort. 350 million in the US. I've done the calculations for New Zealand and it's about 5 million because we have a much smaller um,
Yes, yes,
sample.
yes.
We have
But
fewer
basically, you're
births.
saving US $3,000 per person, I think.
Yeah. Yeah, I know. So cost savings are big. So even if, it's not for the benefit of the mom in terms of her depression, at least you could, I've heard that I've started to hear sort of some of the resistance to our data. Um, but it's hard to argue on the cost effectiveness side of it. And it's something like that I was told that we know that while it's known that the babies are born a little bit earlier if they're on an antidepressants, and of course there's conjecture around why that might happen. It's only a few days earlier, and of course the benefit to the mom is important and obvious. And I'm like, but that means that the whole mean drops, and that means you increase the likelihood of that group having premature birth because the whole mean goes down. Um, and the cost to society is not insignificant when it comes to that cost of that preterm birth. So, for that reason alone, we should be looking at other alternatives to see if there's, something else that it doesn't have that potential harm. I'm being very careful on this one, but I figure if it really is the depression that is causing that premature birth, there shouldn't be any premature births on antidepressants because the mom should be treated. End of story.
We need a language where we actually can criticize synthetic drugs and we can criticize nutrition. Let's equally be able to criticize synthetic drugs. And I just want to finish up because you referenced in one of your papers the 2020 Royal Australian and NZ College of Psychiatrists clinical practice guidelines for mood disorders, and it is behind a paywall, but I do urge people to try to access it, and I particularly urge medical doctors, psychologists and psychiatrists to look at it. They talk about the recommended psychological interventions and lifestyle changes and pharmacological treatments, and they're pretending that they've done a methods-based review. They're pretending they're looking at the literature. This is a 2020 paper. Ruckledge and colleagues have been producing papers on nutrients since about 2009. I think that was the first the OCD paper, and another paper came out in there. You've written a book that if you look on PubMed, if you look on Google Scholar, you will find dozens of papers under Julia Ruckledge. Felice Jacker in Australia released in 2017 the SMILES trial. So, yet this so-called review by the Royal Australian and NZ College of Psychiatrists have completely ignored the impact of multifactorial micronutrient supplementation that is intended to work synergistically and that is intended to address deficiencies or the inability to absorb. Do you think they should be including your work and the work of Felice Jack and the work of other people, particularly in Australia and New Zealand, that are looking at micronutrient mixtures?
Well, what do I say, Jody? I mean, I know that their defense will be that we don't have sufficient clinical trials, in particular when it comes to depression. At that time, we had not published NOMAD, which is on depression, a trial that targeted depression in adults. So, in all fairness to the broad spectrum micronutrients, did we have any studies that were well controlled, placebo controlled trials on depression? The answer would be not on the broad spectrum, because we targeted ADHD. Some of them had depression. We had some observations there. They are interesting. Yes, they could have been highlighted. They weren't. So that's sort of what I know would be said about why it wasn't included, was that there isn't sufficient enough evidence. So that's where it would be.
But it's interesting because they're talking about the pharmacological treatments that people will be on for a lifetime, and the data isn't there for lifetime treatment.
Yes, I know.
So,
I know, but that's an oversight. There are things that they prefer to not look at. When it comes to Felice's work, you've looked at it more recently than I did. There was some nutritional interventions that ended up in there, so there was some recommendations. So that would have been as a consequence of the influence of Felice Jacka's work. Just knowing who's on the paper. Michael Burke is on the paper, and Michael Burke was Felice Jacka's supervisor. So I know that will have influenced some of the guidelines. So even though she might not have been directly cited, I'm surprised it wasn't. But then it might have come out. I don't know what these things get written, and then some years can go by before things get published. So I can't remember the timeline on that.
Reviewing a few individual nutrients.
Yeah.
Is there?
Yes, they did do that. Yeah, that's right. Yeah.
Is there anything you would like to finish off with?
I mean, I really just hope that this is that when people hear about this, they don't immediately close their mind to it, that they show curiosity and interest, delve into better understanding the role that nutrition plays in our health, better understanding why it is that supplementation seems to be so necessary in the 21st century, understanding that the nutritional environment that we live in now is so much more depleted than it was 100 years ago. So our need for supplementation has gone up. I'm not here to supplement the world. I'm here to make sure that our brains are well nourished. But we live in an environment, a toxic food environment now, where we are full, our stomachs are full, but our brains are empty. So our brains are not receiving the nutrients. I like to call it hidden brain hunger. It is creeping up on us, and it's evident in the statistics around mental health, poor mental health in our communities. And I just really, really hope that, and I don't have a lot of hope that our government is going to pay attention to this. I've done my best to try to bring this to the attention of our new Minister of Mental Health, but it so far hasn't had any impact. And it just saddens me that we keep thinking that the way to solve the mental health crisis is just training more mental health professionals, rather than looking upstream to see why it is that we are having so many mental health problems in the first place.
Thank you, Julia. And most of your papers are not behind paywalls. They can be found, Julia Ruckledge, on PubMed or on Google Scholar. As well as that, the Better Brain is available in New Zealand from Whitcoulls, and you can also buy it on Amazon. It's one of the first, I believe, books on nutrition, mental health, and micronutrients, and that is looking at complex formulations. And it was published, I think, 2018. So it's been around for a while now.
21.
Oh, 2021. Yeah. So it's fantastic. So that was with Bonnie Kaplan. So thank you very much for today. I'm really grateful for your time.
My pleasure, Jody.